I've been reviewing the numbers from the WHO during the last 2 weeks, actually, quite carefully. And I wanted to tell you that as we look at reported cases of COVID disease around the world, there has been a marked drop in numbers during January. So we were really up at something like 500,000 new cases reported per day, at sort of approximately at the 1st of January. And then by the time we reached the second week of February, or we're just going into it, we are down to 300 to 400,000 cases a day. I mean, that's a very interesting drop. That's a 40% drop in numbers of reported cases each day during the space of a month. Now, those of you living in the UK will have seen a remarkable drop in daily incidence from a very, very high level indeed, about January, February, and then down by a reduction of over 50% in the daily reported case rate. But also the numbers of daily reported cases in France are plateauing. The numbers of daily reported cases in the United States have dropped as well. It's as though simultaneously in several countries in the Western Hemisphere, there has been a marked drop in case numbers, and death numbers are also falling. They're coming about 2 to 2.5 weeks after the case numbers have plateaued and dropped. How does one explain this quite marked shift? Answer, my own view is that in Europe, a combination of quite significant movement restrictions through locking down and higher levels of personal protective behavior. It's as though there has been a widespread recognition among various sections of the population that unless you do physical distance and wear masks, you are at risk. And so there has definitely been a combination of factors leading to the fall. And I think that is leading to a real sense of excitement. Now, in some countries, there is a suggestion that vaccination is making a difference, but we have to remember that 80% of the coronavirus vaccinations that have been given have gone to people in 10 countries. And it'd be really difficult to ascribe this massive shift in a lot of settings to vaccination. In fact, I want to discount that. However, data from Israel are suggesting that the high coverage of the country's population with a BioNTech vaccine is reducing severe illness and death. And I want you to hold on to that. The vaccine reduces severe illness and death, but I'm not sure that any of us believe that we've yet reached a point where we can say the vaccine has led to the pandemic intensity reducing. So one could say, oh, great, it's good news. But it's just so clear to me that that's an incomplete story. The data that we have available is not telling us what's really happening. I've got another role, which you know about, which is helping to organize Food Systems Summit dialogues. And in the process of doing that, I've had conversations with colleagues in Malawi, Zimbabwe, Tanzania, Mozambique, Senegal, conversations with colleagues in Bolivia, Paraguay, Ecuador, Chile. And each group that I'm talking to is telling me actually things are really difficult where they're working. They've got much bigger surges of COVID cases. Hospitals are full. It's very hard for people to get admitted. And unfortunately, there are various signs to suggest quite high levels of death. And just remember where we're getting these reports from. Sub-Saharan Africa, Southern, West, and in some places East, and Latin America. Not so much from the Indian subcontinent, quite high case numbers and bad news from Malaysia and Indonesia. It's very patchy. And what one finds is that when we get a high level of disease and death, as I've said before in previous briefings this year, it's super localized. And I suppose that leads me to share with you a growing feeling that I have that the way that COVID is going to go on presenting itself is with localized spikes of high levels of sickness and death, presumably due to spreading events that have occurred on a backdrop of relatively low incidence. I still don't know how important asymptomatic transmission is in this. I still don't know what leads to a sudden surge and an explosive outbreak, but it's happening. And even in Europe, right now, I've been telling you that things in UK, France, and some of the Northern European countries, Ireland, are looking better. But actually in Italy and in parts of Spain, it's not looking so good. So I want to hold on to the reality that there will be localized deteriorations, localized buildups of infection and surging on this backdrop of hopefully lower levels in the wider population. Now, several of you, I'm sure, are getting reports from colleagues about really dire situations in some settings. What are the indicators that tell us whether something dire is happening? If you're working for the United Nations and you have staff and dependents who are working in your teams and they can't get into hospital because there are no beds, that's an indicator. If you're having to get special facilities for people who are severely ill, like medical evacuations, that's bad news. If there's a localized shortage of oxygen in your area, that's worrying. If there are signs that healthcare staff are getting ill and dying, that's obviously an anxiety. And these are being reported now all over Africa and all over Latin America. If this is happening, the reaction of governments will almost always be to do total movement restrictions or lockdowns. Those lockdowns in poor countries are associated with rapid impoverishment. Most developing countries do not have enough cash in the bank to be able to provide social protection support for their people. So the immediate impact is an impoverishment that is associated with hunger and malnutrition. The World Food Programme tell me that they have increased requests coming through from governments and communities to provide food for emergency support. Schools are still closed in many developing countries. Children are at home. In some places, they've missed as much as a year's education. There are things that happen in the home which are associated with life not being right, such as violence, violence against intimate partners, and then violence of various forms against children leads to pregnancy, child marriage, and all the figures suggest that those are on the rise, just as we've seen big increases in mental ill health and violence against intimate partners in Europe and North America. The social and economic costs are still very high. Why am I going on about this? You've heard me saying it for over a year. I was listening to the video that we played beforehand and just thinking, this is still so important. But why am I going on about it? Because I am worried about collective amnesia in wealthy nations about the reality that this is a global pandemic, that this is really hurting people in poor countries, that this is particularly hitting poor people in poor countries. Health systems are overwhelmed, and we absolutely must not be blind to it. We have to approach this pandemic as a global issue and not as a local issue only. Yeah, okay, so that's my basic statement. Of course, I've woven that into whatever public work I've been doing in the last week. Last Friday, I mentioned I was doing a difficult interview, I thought, on Sky Television, Sophie Ridge on Sky, and I discussed with you what line to take. And I was as honest as I could be, whilst at the same time recognizing the enormous sacrifices that people are making with their movement restrictions, the extraordinary impact of those movement restrictions on incidents in Europe. And I think that one went okay. I've done subsequent ones. I'm trying to really reduce them because I find it so difficult if I'm asked to speculate on things that I know nothing about. So I've tried to reduce media work, but to go for moments when I can get longer time in the interviews in order to try to really make the point that this is international. So last Tuesday, I spoke with an Irish parliamentary committee, and the specific issue was developing countries. And I really sought to make the point that this is a situation now which is really bad in developing countries. Thank you, Catherine, for sending me the notes. I'll just keep talking for a few more minutes and then I'm going to open up. Again, Ian Norton, I want to come to you first, if you don't mind. So the vaccine situation is really difficult because there's a shortage of supplies and a massive demand from a small number of countries that have decided as a matter of policy to try to rapidly immunize all their adult population. Now, Tedros of WHO, and as well as a number of other commentators, in particular, people in public health around the world, have all been saying the right thing to do with this vaccine is to make sure that it is given to older people, people with ongoing disease like diabetes and hypertension, as well as healthcare workers. And Tedros wanted to get the world to pledge to immunize all the healthcare workers within 100 days, because as far as he's concerned, and I think as far as most people are concerned, now that we have vaccines coming on stream, the right thing to do is to ensure that those most in need receive them. So we've been making this point on media and in webinars all last week quite strongly, talking about the absolute need for vaccine equity and the dangers of vaccine nationalism. Now, of course, everybody, I think, can understand that if a country has a lot of doses of one of the potent vaccines that work, then it'll be very hard for politicians and people to say we should be sharing our vaccine with the rest of the world because of the damage being done by the virus. And I have had massive pushback for advocating for vaccine equity, massive pushback, particularly from people in the UK, and they can get very violent and unpleasant on social media, or if they've discovered your email address, writing emails to you. And I hadn't realized, I suppose, just how prevalent is the sense that if we have a vaccine, we should use it, we deserve it, we've suffered so much, we've had lockdown and misery and death for 10 months. And how can you international figure, be so anti-British that you're saying that we should share our vaccine with other countries, we should focus on immunizing our people, and that's that. And I suppose that that sentiment has now got through to politicians, and so we have the spectre of northern countries doing quite a lot of underhand activity to lay their hands on vaccines. And you could say, well, it's all fair. If a country wants to pay more for vaccines, it's their right to do so. And if they can also persuade a company to put them higher up in the queue, it's their right to do so. But I think at least most of us who are working for global health and global well-being find this just all a little bit unpleasant, especially when we hear of strenuous efforts being made by governments of regional blocs and of nations in the north to actually try to divert vaccine that's licensed for and intended for developing country use to pull it into their own borders for their own national use, i.e. deliberately trying to undercut supplies for poorer countries. And of course, the ultimate scheme for supplying poorer countries is COVAX, which is a scheme which offers negotiated prices for anybody who wants to buy a vaccine as a result of its effort to get the best possible deal for countries. And so COVAX, a bit like some of the predecessor vaccination programs done by the UN, has done advance purchase orders for millions of doses of vaccines from the different manufacturers in order to be able to offer low price vaccines. And there are two groups of countries in COVAX. There are about 100 countries who are actually able to get vaccines through COVAX that are subsidized by donor finance. So they can get low cost vaccines or zero cost vaccines, and they can also get help with their plans for administration of vaccine, their national vaccination plans from a combination of donors and the World Bank. And as I say, there's about 100 in that subsidized group. But also wealthier countries can buy vaccine through COVAX if they wish and get their vaccine also at the negotiated price, but they just have to pay full price. And there's about 90 countries, 80 to 90 countries in that group. Overall, there's about 180 countries in COVAX. So it's about 90 each side. So this means that the COVAX scheme is brilliant for everybody because you get your vaccines, lowest cost that's just about available anywhere, and you get them either subsidized if you're a poor country or at full cost. The only problem with COVAX from the point of view of some countries is inevitably there's a queuing system, but it's a queuing system that's done on the basis of need and readiness rather than a queuing system that's done on the basis of how much you're prepared to pay. Now, because of the political pressure with leaders feeling that their survival depends on their ability to show how good they are at getting vaccines or jabs into people's arms, what's happening is that there's a huge incentive on some governments to go bilaterally to the manufacturers and to try to bag or get some vaccines early to sort of jump the queue through a bilateral arrangement. But of course, inevitably, that means they have to pay more than the negotiated COVAX price. In some cases, countries are reported to have paid twice as much or even 3 times as much per dose for the vaccines in order to try to get closer to the front of the queue because of a political necessity to do so. It is rumored that South Africa had to do that. Now, all that would be okay if there was loads of vaccine around. But obviously, by bypassing and going direct to the manufacturers and being prepared to pay more, some governments are actually pulling vaccine away from the COVAX system, which in turn delays the planned rollout of vaccines over the first 2 quarters of this year to poor countries, which in turn further stimulates them to go round the corner to try to get vaccines through bilateral deals. COVAX will only supply vaccines that have been approved for emergency use by the WHO. There's a several-part process to that. You have to have a committee of experts review the data on the vaccine, and then you have to have the approval process done by another group. And right now, we've actually got 2 vaccines that have been through the WHO process. One of them's been approved, the other one is about to come. The news this last week, actually published yesterday, was that the WHO Advisory Committee of Experts had decided that the Astrazeneca Oxford vaccine, which is a vaccine that can be kept at a normal fridge temperature, and it's quite cheap, that this vaccine is getting a WHO license for use, including in over 65s, which was a bit of an uncertainty in some countries, and also that they're saying if you want to use a longer dose interval between the 2 doses than the usual 4 to 6 weeks, that is okay. And in addition, the Oxford AstraZeneca vaccine has been demonstrated in research through early studies to be quite effective in dealing with the UK variant of the virus. So that is good news. But during last week, there has been some anxiety because the South Africa variant, which has a mutation, which I just checked before this, called E484K. It's a mutation in the spike protein that binds onto cells. It turns out that the Oxford AstraZeneca vaccine may be much less potent at protecting people against the South Africa strain than it is against the original. I think that does put a bit of a cloud on what I think most of us thought would be the miracle vaccine. The general view from WHO colleagues is that it's less effective against the South Africa variant, but they think that it still has some effectiveness. But the South African government, it would now like to give back some of the Oxford AstraZeneca vaccine that it bought at slightly higher price because it had to rush to get some vaccine because of the high amount of disease in the country, but it wants to give it back and swap it for the Pfizer-BioNTech mRNA vaccine, the one that has to be kept cold, because at least the Pfizer-BioNTech vaccine works against the South Africa variant. In conclusion, what are we seeing? Well, the variants are clearly an issue. The variants change the capacity of the virus to be neutralized by antibodies and indeed by T cells, which are the cells for cell-mediated immunity, when using some of the current generation of vaccines. Andrew Pollard, who is the virologist who was behind the development of the Oxford vaccine, gave evidence to the British Parliament last week, and he said it really does look as though the constant mutation of this virus is going to mean that, a bit like flu, at intervals it'll be necessary to tweak the vaccine and to come out with boosters that are effective against the variants as they are discovered. Now, we've got to reduce the amount of virus in the world to reduce the likelihood of new variants emerging. We need to reduce the likelihood of new variants emerging because as soon as new variants emerge, they will have the potential ability to be able to escape the vaccine. That's what it's called, vaccine escape, to escape the vaccine and still cause trouble even though people have been immunized. And there's a real possibility that as a person who's been immunized extends the interval after the immunization, so that person's immune response gradually declines, so they may find that the variants break through quicker and can actually cause disease. So we will be, science-wise, chasing the variants for the foreseeable future. Is this all impossible? Does it create an impossible problem? No, that's how influenza works. Every year, influenza vaccines are readjusted to the new variants of influenza that are coming along. But to do all this, you need to have a really good global surveillance system, and there is a massively well-developed influenza surveillance system. You need to be able to sequence the genome of the virus in order to see whether it's evolving, to trace the variants, and then you quickly dial up the manufacturers of vaccine. You say, here's the structure that we're going to have to include in our vaccine for next year, and they get to work and they do it. It's a rhythm. I mean, I can only tell you about this because I was involved in it a bit about 10 years ago. We'll have to have that same approach to coronavirus, COVID-19, but it'll mean a global surveillance scheme to do genome mapping, and it will need a really good organization with the vaccine manufacturers. And the situation's got to calm down a bit, because the present kind of massive rush to try to immunize as many people as possible, otherwise you're a lousy prime minister, that stuff is not actually helping us, because it is leading to a very unstable situation. Therefore, my advocacy this year is going to be, expect the variants. That's going to be the shape of the future. Expect them to break through and escape the vaccine from time to time. That's inevitable. And get the global system properly organized to be able to deal with the variants as they come, and level with the global public that this is what we're doing, and stop all this stuff by saying we'll vaccinate everybody and then we'll be back to normal, because that's not fair to people. So I talked to Helen Clark, who's really one of my gurus in all this stuff, and who's leading this panel that's looking at the WHO response. And she says that she thinks, as do several other leaders that we're in contact with, super important to level with the public about what's going on. Even if people are going to say, you doom merchant, you misery guts, we've got to do it. So that's really trying to tell you my core view about what the future looks like. I will do that repeatedly in these briefings unless my position changes. I will give you the evidence as best I have it. And I will also tell you from time to time about points where I'm super excited. And I think the really excellent work being done by the vaccine developers to think hard, have we got to change the target? Should we stop using the spike protein? Is using the spike protein on the virus as the target for the vaccines creating a vulnerability? Because if the spike protein mutates, which changes the infectivity of the virus, but it also may invalidate the vaccine. And there's a lot of interesting work now from various companies changing the target, making the whole virus the target, or making another part of the virus the target, which might mean that we'll have vaccines that can deal with more of the variants. Just to say, I'm pleased that several Chinese vaccines are coming through, and that the Sinopharm vaccine is now, the Sinopharm company have put the dossier for their vaccine into the WHO approval process. And there's a team in China looking at the manufacturing practice of that vaccine. And if, as I suspect, that vaccine gets an emergency use license, that is very good news, because there are several countries that have already started using or planning to use that vaccine. I'm not sure whether they're using it because they can't get a hold of vaccine from other sources. WHO is also in contact with the manufacturers of the Russian vaccine. That's the Gamaleya company in Moscow, and it's the Sputnik 5 vaccine. There is a lot of work on just going through the manufacturing I've learned that the whole good manufacturing practice thing is super complex, but it's very good that WHO's had several meetings with Gamaleya on that. Once these vaccines come on stream, and also the Johnson & Johnson vaccine, single dose vaccine, which is currently under development, when that's come on stream, hopefully this terrible time of vaccine shortage will be overcome, and it will be possible for vaccines to be available more widely. And just, I have to tell you, this is important. Again, back to what's really happening, health workers dying in increasing number, particularly in developing countries. And, you know, I don't want to be in a world where the vaccine's being sucked up in one part of the world and health workers are unable to get it in Ecuador, in Peru, and in Malawi, and in Tanzania, where it is badly needed. So I've gone through what I wanted to talk about. I'm accepting that some of this might be confusing. What I've got, for those of you who might need it, I have got quite a lot of updates on, particularly on COVAX, and on what the situation is on the variants. And any of you who would like access to that information, I can try to make sure that we can put it up and make it available. Thank you very much indeed. I would like to go to Ian, and then I will go to Twee for the halftime thing that we normally do. Ian Norton, please, from Australia. It'd be great to hear from you. I think you might be in Brisbane.
Thanks, David. Yes, just north of Brisbane on the Sunshine Coast. But maybe a couple of points on Australia, and then I'd love to say something about the Pacific there and some work that's evolving. But and if there are any colleagues online who have closer to the field, it'd be great to hear back from them. The first in Australia is vaccine, and it resonates with us. There is a moderate amount of Pfizer coming in. It's just been approved by our TGA, which takes a long time. It's quite robust, but it hasn't arrived yet. And Astrazeneca will be made onshore by the CSL laboratories in Melbourne, particularly. So 50 million doses, and then they will change their production to Novavax for another 50 million. So more than we need domestically, but hopefully things we can export after. The problem is there's vaccine hesitancy, because at this stage, Australia is in a good place, a lot like New Zealand, or slightly behind New Zealand. And there's a lack of clarity between the states of Australia in, are we chasing a containment model, which particularly the federal government and New South Wales government want to follow, versus an elimination program, which is quite clear in Queensland and Western Australia and other places. And there's friction between those governments, unfortunately politicized, because there are different types of government as well. So that's a big issue, and vaccine hesitancy is playing in a little, because they're watching what's happening with AstraZeneca and saying, if we're looking for elimination, shouldn't we go for the most efficacious vaccine? And that's gone round and round. The other thing to inform everybody on is quarantine, and Australia has this effectively a fortress approach with quarantine at the moment, but we've had multiple breaks in that quarantine in the last few weeks. So each of the states have had a major breakthrough, except for Tasmania and the two territories we have in Northern Territory and the Capital Territory. All others have had breaks. It seems to be aerosolization, some pressure issues between hotel rooms and things. There's a big debate going on here nationally now about whether we should use a centre, which I still support, up in Howard Springs in the Northern Territory, where it's a camp, an old disused mining camp, and people in quarantine are housed there in good terms. Mental health is good there because you can get out on a balcony, it's open air, but it also seems to be helping with infection control. Now, looking at our Pacific colleagues, Tonga have looked at what's happening in Australia, are getting worried by this, and now have increased their quarantine time from 14 to 21 days. They watched some breaches in New Zealand and in Sydney, where people were found positive on day 16 and day 18 with the new variant. So it seems to be a variant issue on that. But I do want to say a word about the worsening economic situation across the Pacific. It's gradually getting worse and worse, particularly from lack of tourism, a major mainstay of economies. Some of the extractives and fishing and other industry, they just can't move people in and out, and therefore are suffering. Hearing reports of some food insecurities even in some islands, which is awful. There's also a lack of labor migration. This is a normal part of this part of the world where seasonal workers from the Pacific come into Australia and New Zealand, earn money, and the remittances that usually go home have all stopped, of course, and therefore there's a lack of money flowing back into the economy back home. And the last on the Pacific, and I may be slightly controversial here, but there seems to be a creeping politicization of vaccine supply, and particularly from major powers in the region, and a use of soft power around vaccines, and that's disappointing to see. But I'll pause there, David.
Thank you very much, Ian. It's just absolutely great to see you again and to hear this. I think we, on these calls, we mustn't feel bad if we're sharing slightly depressing news. I don't ever want these briefings to be coated with a sense that we have to have sort of good news as well as bad news. We just have to be saying it like it is. The style is honest, honest, honest. And honest means honest to your values and honest to your understanding of what's going on. And Ian, thank you particularly for talking about the situation in Pacific Islands. Of course, all communities that depend on tourism or on seasonal labor that moves across borders are in desperate trouble all over the world. Pacific, Caribbean, and of course, the African, Asian and Latin nations that are highly tourism dependent. And that possibly is the toughest part of this. Many countries have actually been able to really build up their economies by developing strong tourism pipelines, like Maldives and so on. They're in super difficult situations. So important we saw that. The indicators of things going wrong are people queuing for food. And I picked up 2 of increasing situations. The other thing I picked up was a real shift back from using sort of food supplies to homegrown. And I was hearing even the president of Fiji has taken to extolling homegrown production over imports. Thank you for stressing about the politicization of vaccine supplies. There are a number of countries that have got excess vaccines. My advocacy is for them to give their excess vaccines to COVAX so they can go out through the needs-based system and not to just go into the business of offering 200 million doses in return for political concessions. Of course, all of you know that that's going to be stunningly difficult, and we'll have to build up really strong lobbies working with NGOs who are beginning to get hold of this issue to make certain that we don't end up with what you just called, Ian, vaccine soft power. I hope you will develop a nice, juicy expression for that one, because we need to really talk about that and talk about it really publicly, because we know that that's what's just around the corner, or it's happening already. Thank you, Ian. Lovely to see you. Stay on. Now, I'm going to ask Twee to just give us the short break, and then we'll quickly go into the second half. And then I'm going to comment on several of the points that you put in the chat. But I'm particularly wanting to hear either direct or indirect stories from what's happening around the world. And Joe Nichols, I'll come to you immediately after Twee. Twee, over to you, please.
Thank you. So just running a little break quiz to interact with you and give David a chance to catch up on the number of questions that you've put on the chat. So launching the poll now. Question 1. Oh, that's not the right poll. We want this poll. Question 1. Which of the following events is the most prominent in the history of bioethics? The Flint water crisis, doctors endorsing smoking, or the Tuskegee syphilis experiment? Question 2. The International Health Regulation is an internationally binding instrument of international law on infectious diseases. Prior to 2005 revision, it was specific to only 3 diseases. Which 3 were they? Cholera, plague, and yellow fever, smallpox, cholera and plague, or meningitis, malaria and yellow fever? And the third question follows on from last week's, where I did not include singing and dancing. Now, please let me know, have you continued singing and dancing despite the pandemic? 3 answers there. Yes, but I'll keep how to myself. Yes, and you'll share how in the chat. And no, you are just waiting for it to be safe again. I'm going to keep that up for the questions to come through, and we'll just do a quick look at Chris's illustration so far. Fantastic.
Chris, you never cease to amaze me. Wow. Thank you. Beautiful.
Great. All right, so I'm going to stop the poll in 5, 4, 3, 2, 1. Now, sharing the results with you. For question 1, the answer is indeed the Tuskegee syphilis experiment. A terrible experiment I learned about yesterday, thanks to Catherine, who helped me with this question. And I think a nice reminder that whenever there are new treatments and illness sort of combinations, there are lots of processes to go through on safety, effectiveness, but also in ways that respect human rights. And in medicine, that's a field known as bioethics. For the International Health Regulation, indeed, the 3 diseases were cholera, plague, and yellow fever. The 2005 revision makes it more broader and it's not specific to any diseases. And so for more information about that, I'll share a link in our LinkedIn chat. And then for number 3, we're hoping, so most of you said you'll share in the chat, so I'm hoping to see some nice messages there or in our LinkedIn chat about how you've kept singing and dancing despite the pandemic. Thank you all. Back to you, David.
Brilliant. Lovely, lovely, lovely. We'd probably also, as well as putting details in the chat, just a little video would also be fun. Thank you, Holly dancing in the kitchen. Great. There was just perhaps Joe Nichols, if you've got a moment, if your video's gone off, so I don't know whether you're still connected. Here you are. You were writing something about the situation in Mogadishu, which I'd heard of a little bit from other sources, but because you are so connected into Somalia, could you share that, please, Joe?
Yeah, certainly. I mean, what we're hearing at the moment is that there's a lot more patients in the hospitals, specifically Di Martino Hospital, which is one of the ones that's supported directly by many of the UN agencies. And civil society are saying that there's more patients, and they're also saying there's shortages of oxygen, which is confirmed through the Ministry of Health, but there seem to be challenges in identifying how to solve the oxygen crisis still. And they're also looking at how they can extend the facilities, including through using tents, maybe through using, regular cholera type tents to make sure that more patients can be treated. And there's a lot of other reports as well of people both in Somalia, in different places in Somalia, but also in Tanzania, of having relatives that have died of pneumonia and that kind of thing, which and then some people being isolated in other contexts, but not for COVID-19, for other illnesses. So yeah, the reports seem to be quite concerning and coming from a variety of different sources.
Thanks, Joe. And so the general situation we're getting, which is well exemplified by the reports Joe has received, shortage of oxygen, shortage of medicines, health workers sick, difficulty of getting into hospital, pneumonia deaths in and around hospital, sometimes clusters of deaths in villages, altogether suggesting stuff is not right in various settings. It's hard to form a complete picture. But Tanzania, you see, a government that says there's no COVID and all that, but just report after report of can't get a bed in the hospital, can't get medicines. Dar es Salaam and Mbeya, in the south, and then further north towards Arusha. There is definitely, in East Africa at the moment, stuff is not right. And in Malawi, as I've said, particularly not right. Unfortunately, some deaths of MPs, senior civil servants, a lot of police, and so on. And then the same story from Senegal and a bit from Ghana. Now, Anne Hendricks Jenkins, you actually alerted me to this going on with some reports I think you had from Senegal. I think what I've noticed in the last 2 weeks is that these reports are becoming more frequent. And I don't think it's just because I'm listening more, but I actually think there is a rise. It's just we don't have data. And if you look at the data for Africa, there's no sign of this going on, but there's something happening, in my opinion. And am I right, according to your informants, please?
Well, sort of based on what you described before, which is people telling about people they know who are sick or dying. A lot of our calls, people are reporting the deaths of relatives and they're not sure why. So I have a fear that it's widespread and just completely going under the radar because of lack of testing. And also because of all the conspiracy theories and the religious guidance, I think there's a special kind of stigma around being someone who has COVID. And also with the decolonization sort of atmosphere of the last few years, I think there's a lot of mistrust of information from the West. Yeah. So what we're seeing, what we're trying to frame it as is people have the right to information and they have the right to make their own decisions. So that's how we start the vaccine conversation, instead of saying, we're trying to convince you to take the vaccine. And then when you look at it like that, and then you talk about different kinds of information, there's disinformation, misinformation, lack of information, good information, and cultural information. A lot of Africans feel quite strongly that the West is not taking their cultural concepts seriously, and that they are proven, so we say, just because something hasn't been studied by Western science doesn't mean it's effective or not effective. The first thing you have to look at is do no harm. And also some ministries of health are actually addressing specific cultural practices. The Malawi Ministry of Health has guidance on cultural practices to address COVID. So there's that. And we had a guest speaker, Joyce Banda, former president of Malawi, on a recent event. Yeah. And 2 days later, her son died of COVID in the COVID treatment stadium in Malawi. And yeah, and they've lost a lot of ministers. Anyway, the one other thing I want to say is that local civil society is responding the best they can with practically no resources at all. So if we could recognize and get resources to them, they are doing incredible work. And trying to share good information and address the food issue, which is probably the top issue of all. So thanks for that opportunity to share.
Everybody, just don't forget it's happening. Joyce Banda's son died. A lot of cabinet, I told you 2 cabinet ministers died, definitely in Malawi. They've made a temporary hospital in the stadium. It's quite unlike other temporary hospitals around the world. This one has patients. And I really want to support what Anne said. This is a time when NGOs are vital, and yet NGOs are really short of funds. Even getting money from embassies is hard for NGOs at the moment in Southern Africa. Super difficult. And thank you. Please keep us in touch. On oxygen, the oxygen crisis, I'll try to get a little bit more information for our next briefing on that, because there are groups all over trying to help get better oxygen generation facilities for poor countries after what's happened in Manaus and Amazonas, where there was a complete oxygen stock out. But also we've got oxygen stockouts in other places in Latin America and in Africa. Thanks, Anne. Thanks, everybody, for that. Just wanted to say to Magan Mutefa in Gaborone in Botswana, we tried to tune in to you from time to time when we see you on. We know you have a difficult internet situation. So Megan, how is life? I don't have up-to-date reports coming my way from your country. Would love to hear from you if you've got anything to tell us. Megan.
Okay, hi David. Yeah, the situation is getting worse as well. But Botswana is resorted to not closing. They say the last lockdown, they spent 4 billion feeding people in the rural areas and even in town. So they are not going to call for a lockdown, but now we have more cases and more deaths. Apparently at my workforce, as I speak, the HR department, the whole building has been closed because there was COVID-19 there and one of my colleagues died, so they had to close down. So there's no one working there and we're still trying to work from home. Those, you only go to work when you can't work from home in certain instances, but we're just trying to practice all that is required to keep ourselves safe. I even went for testing last week, but one, because I'd been in the HR building as well. I actually visited the woman who died, but fortunately I just stood by the door and she was wearing a mask and I was also wearing my mask. So I tested negative, so I think I'm okay. But yeah, the situation is getting nearer home and everyone has relatives dying from COVID now. So it's a bit dicey.
I'm sorry to hear that. As you say, when you know people who are dying, it sort of feels different, doesn't it?
Yeah.
Sorry about your colleague. That must have been pretty rough.
Yeah,
thank you.
She was also diabetic.
Oh, yeah.
Yeah.
Difficult. Diabetes, high blood pressure really do add to the risk. So I think, Megan, we're sorry about that. Thank you for talking to us. I just wanted to see if Peter Scott Bowden, is your sound working, Peter? Where are you, Peter?
Yeah, hi, David. Nice to listen in. I'm actually back from Afghanistan. I got back from Afghanistan in the end of December last year, but the situation when I was there was not good, and especially related to food. In terms of food insecurity, significantly increased since the beginning of the pandemic by about 30%. So, and that's coupled with similar types of issues as you describe, lack of oxygen, overwhelmed health services is certainly having an impact in Kandahar, Herat, which is, as you know, in the western part of the country near Iran, and Kabul itself. Thank you.
And are you working on the WFP response now, or have you shifted?
I've shifted. I've actually left WFP, but I'll talk to you offline about what I'm planning to do now.
Look forward.
Thank you.
Thank you, Peter. Peter Scott Bowden and I worked together on loads of issues to do with influenza pandemics when he was working with the World Food Programme in Afghanistan, which is why I just connected to him. Vicky Doyle, please. You put a notice in the chat, and you have brought all sorts of excitement to people's lives with the lyrics and songs that you and Nazim have been producing. Tell us where you're at with all this.
Well, actually, Nazim's just finished recording now in the studio his latest song, Respect, which is all about trying to change the conversation and focusing on people as the solution, stopping to tell people what to do because people are getting COVID fatigue. So just trying to kind of change the messaging a bit and give a bit of joy to people in these difficult times. It's all about trying to keep people going, not to give up, and to look to those COVID rocks, those heroes who are keeping things going, whether it's isolating, staying at home, being on the front line. So we're talking about COVID rockers and rollers, and trying to give a bit more of a just create some fun and sort of life for people to realize they've got to keep going. So that is just finished recording it now. So we're trying to work on a video as the next.
And it's still got the positive vibes in it, has it? I hope so.
Got the positive vibes in it, yeah. So hopefully we should be ready to share that very soon. There's been quite a few problems with power in Gambia and the internet totally down. So it's taking a bit longer than we expected.
There's lots of lovely stuff in the chat. You know, everybody, if we are saying people are the solution, which is really Nazim's message, and I think it's my message. I've just done a thing for a US event called SXSW, South by Southwest, really, really pushing that. But if it's people are the solution, then we have to find a way to get that into our language. And Anne has written a very important comment in the chat, that language matters. So let's keep thinking about that. We've had with Rebecca Cantor the idea of doing a sort of lexicon of terms. Let's keep focusing on how we can get our language right, so it's empowering and strong, because this is the marathon. It's going to go on, and then we might as well do everything we can, as we said all last year, to help build the strength of people so they can stand in their power and really hold this thing back. It is up to us. Yes, technologies will help, but it's up to us. With that, I'd like to go to Twee to just close us out and tell us a bit about what we'll do next week and how we'll keep in touch in the interim and make sure that we are keeping each other strong. Over to you, Twee.
Thanks, David. We'll be back next week, Friday afternoon, Central European time. And as always, please keep the conversation going in our LinkedIn community chat. If you're not yet there already, send me a message on LinkedIn and I'll be able to add you. And then to end, let's spotlight Chris Shipton. Here is his live scribing from the session today. Chris, do you want to have a word?
Yeah.
Hi, David. Hello, everyone. Good personal news. My parents are getting vaccinated today.
Very good.
So, you know, it's nearly as emotional as Christmas being cancelled.
Yeah. How old are they?
Well, I mean, they're sort of an undisclosed age, but they're very, very close to 70.
Yeah. No, it's over 65. Very good. All over 65s. Please get vaccinated if you can, if it's available. I think it's great. Thank you, Chris, and thank you so much for the picture. That's just unbelievably good. I like the calm down. So everybody, thank you for joining. Now there's lots of comments in the chat, and I just, as we close, to Marianne, she says, is WHO strong enough to undertake global leadership on vaccine etiquette, a lovely term? Should G7 or UN General Assembly take this on? It is rather distressing to see so little vaccine distribution. So number one, COVAX will click into gear. It took a bit of time for the vaccines to be authorized by COVAX, partly because it's a slower process, but partly because they had to get the companies to provide the data. But now that the approvals are coming through, the COVAX process will work, and we will see a gradual tilt away from 86% of vaccines being given in rich country, or in just 10 countries, to a more equitable spread. But yeah, I mean, I think the question about whether the UN or WHO is strong enough to help the world through this situation is super interesting. I think, is WHO Director General given the space and opportunity to lead? Not sure, but I think it's coming, and I think he's been very clever in sidestepping a lot of attempts to try to push him down by various people. By the way, all of you, I don't personally want anybody to be disrespectful about the early reports from the study of where the virus came from. My own view is that given that there are signs of the virus from people from whom blood was taken in the late months of 2019, I think it's perfectly reasonable that the WHO team should be looking at a lot of alternative hypotheses for origin. And I don't belong to that group that say that somehow the investigation team has let off the Chinese. I don't think that that's a reasonable conclusion to reach at this time. Keep an open mind if you possibly can. It will take a long time before the origins of this virus can be fully understood. Everybody, thank you for joining us. I never like leaving these sessions, but it is with big, big affection and gratitude that I thank you for joining and for you to sticking on to the end. And bye-bye to everyone.